and I'm Grace Halsey, a senior editor of Patient Care Online. And our clinical focus this month is on preventive cardiology and the essential role of primary care in reducing the risk of reducing patient risk for cardiovascular disease. Dr. Jorge Plutzky is with us today to talk more specifically about managing diabetes as a risk factor for atherosclerotic cardiovascular disease. Dr. Plutzky is the Director of Preventive Cardiology and in the cardiovascular division at Brigham and Women's Hospital in Boston, and is currently chairing the American Heart Association's Committee on Diabetes. Good afternoon, Dr. Plutzky.
Hi, thanks for having me, Grace.
Sure. So the American Heart Association considers diabetes to be one of the 7 major controllable risk factors for cardiovascular disease. But unfortunately, we also know that today adults with diabetes are 4 times more likely to die from cardiovascular disease than those without diabetes. So while diabetes, and I'm going to be focusing on type 2 diabetes, is a modifiable risk factor, the role in CVD death suggests that there's an ongoing challenge. So would you like to open the discussion using that as background, the interplay between cardiovascular disease and diabetes?
Sure. I think it's an incredibly important topic. It's sometimes surprising the extent to which patients, the public in general, don't realize and recognize just the simple presence of diabetes in and of itself is sufficient to confer a significant increase in cardiovascular risk without there being other issues at play. As a result of that, really every guideline available in the world will instruct and direct physicians, and especially primary care physicians, to intervene on patients with diabetes in regards to their cardiovascular risk. So that means controlling their LDL levels, controlling blood pressure, and controlling other risk factors to the extent they're present. I think one of the things that's so impressive about diabetes and its relationship with cardiovascular disease is how pervasive that effect is. It really is manifest and evident, not just in heart attack, but also in stroke. It's apparent in peripheral arterial disease. It's evident in microvascular disease that can affect things like neuropathy and nephropathy. And it is a very powerful influence on the vasculature from a scientific perspective that is conveying this kind of risk. So we think paying attention to this is important. I think one of the other examples of that is, when we decide to say that someone has diabetes, inevitably is a little bit arbitrary. We set certain cut points. We say, okay, now this patient has diabetes, but there's quite a bit of evidence that this cardiovascular risk reaches into earlier stages of pre-diabetes as well. And that's particularly important, especially for a primary care audience and for primary care givers, in that patients with pre-diabetes may be the ones that have an opportunity to have their risk be the most modifiable, even reversing the presence of diabetes and keeping it from coming on. So those are all opportunities to mitigate and to control the risks that may be tied up in having diabetes, having pre-diabetes. And of course, the diabetes connection to heart disease is also intertwined with obesity, which is so often present in people who have type 2 diabetes.
Interestingly, the interview that I did this morning was with somebody talking about obesity and management of obesity in preventing cardiovascular disease, and how interesting it is that obesity surgery can very often reverse very severe diabetic disease. And on the flip side of that, how discouraging it is that it's really easy to get to schedule surgery for coronary artery bypass. However, in order to schedule surgery for Roux-en-Y can actually be a difficult and very long suffering procedure. So we've got an imbalance.
Yeah. Well, the data for bariatric surgery and and the impact it can have on diabetes is very impressive. You end up having to use terms like cure because the diabetes goes away. It's not a word we use that often in cardiometabolic disorders. At the same time, we're always stressing to patients and to our colleagues that the metabolic benefits of losing weight are often manifest with the first 5 or 10 pounds. And so we're always trying to get patients who talk about needing to lose 50 pounds, but getting them to focus on the first 5 to 10 pounds, and that you already see very dramatic effects on things like triglycerides and blood pressure, even inflammation, certainly glucose control, certainly pre-diabetes going away. And so that can be appropriate. Of course, there are patients who do need the bariatric interventions, and I think those are valuable. We also have more medications now that can be used to treat obesity, and in that way to get at diabetes. These things all align with the notion of that these are issues for us to pay attention to because they can have such an important impact on outcomes for our patients. And outcomes, down the road, patients don't show up hurting from a high LDL or a poorly controlled A1C, but it's going to hurt them someday down the road. And that's particularly challenging for us as physicians and nurses and other caregivers of trying to convey just how important these issues are because the stakes are high. They're just not hurting right at the moment, but they can certainly hurt you down the road.